So I think that the value of this is that we now have very objective data indicating that these patients do suffer from first difficulty losing weight and probably high cholesterol, so it's sort of some form of metabolic syndrome. And they also have some disruption in their cognitive activity. I mean, they have depression. Unfortunately, the cognition impairment was barely significant, but was almost significant. Now, another finding that we saw that was really interesting is that their physical activity is reduced by 30 to 40%. And this is self-reported physical activity, and it's a very comprehensive report where they tell you physical activity during work, during recreation hours, at home, and it's across the board was about 40% reduced, meaning that they do feel, when they complain of feeling sluggish or low energy, that's what it is. The obvious question is the fact that they don't feel well explained because of the low T3 levels? That maybe. To answer that question, what we did was we created an animal model, a rat model with hypothyroidism. And in the rats, we actually fixed the T3 levels. We brought the T3 levels to normal, and that resolved the problem. For example, hypothyroid rats on levothyroxine have higher cholesterol levels, just like the humans, right? But we didn't give them statin. What we did was we give them a little bit of T3, we normalized T3 levels, and as a result, the cholesterol levels went back to normal. To do the same thing with humans is not as simple. The problem is that the turnover rate, half-life of T3 is relatively short in humans, and when you give a tablet of T3, of liothyronine, what happens is that you have a peak of T3 about 2 or 3 hours later, and then several hours later you have a valley. T3 levels are very low. So as opposed to having a steady level of T3, you can actually have a peak and you have a valley. In fact, when studies that have given back T3 to patients that are on levothyroxine look at the outcomes, it's sort of confusing. I mean, it's not conclusive. Some studies show that by giving T3 they feel better. Some studies show that by giving T3 they don't feel better. If you ask patients, you also have mixed responses. Some patients do well by taking a combination of levothyroxine and T3. Some patients don't. But what are we doing? Are we giving back T3 the same way I gave back T3 to rats? No. When I gave back T3 to rats, I used a pellet that had slow release of T3 throughout the day. So that what I did was I just bumped up T3 levels by 10%, and that made a difference. Now, we have not been able to do that with humans. We don't have the delivery system to provide a steady level of T3 throughout the day at a higher level. We need to develop this. What is that? Maybe cream with T3? Well, maybe, probably not, because the skin has deiodinases that inactivate thyroid hormone. Maybe a pill that you take that releases T3 at a slower rate throughout the day. We need the pharmaceutical industry to be creative here and come up with alternative or additional delivery mechanisms so that we can start to address that question, whether or not raising the levels of T3 will do any better for these patients. No, I think that endocrinologists are more than qualified to take care of diabetes and thyroid issues by far. Yes, absolutely. Probably not for diabetes and obesity, and that's why I said in the beginning of this conversation, general internists are more than capable also of taking care of patients with diabetes and thyroid-related issues, especially hypothyroidism. And when you have a more complex case, that's when you engage the endocrinologist. You have a diabetic patient that is hard to control. You have a patient with thyroid nodule that had a biopsy, and the general internal medicine does not want to handle that, so that will be a referral for the endocrinologist. But the everyday hypothyroidism or the everyday diabetes or obesity, it should be taken care of by the general internist. No, I think it's pretty much being done. I can't tell you across the country what happens, but most academic institutions have this type of thinking, I mean, to engage primary care physicians, absolutely. Hypothyroidism is something that it's going to stay there. We know nothing about what causes hypothyroidism. We know it's a autoimmune disease. The body, for some reason, starts producing antibodies and killer cells that will just destroy the thyroid. And it's interesting, when we treat patients with hypothyroidism, we're actually not treating the disease. We are just giving the body the thyroid hormone back because the thyroid is gone. That's part of the future that's going to be present there. But another interesting challenging for thyroid disease, and probably this is the subject of a different conversation, is thyroid nodules and thyroid cancer. A lot going on in that area, and we are reassessing right now how we take care of those patients.